it's a real pleasure to introduce Dr. Marlene Kuhneman, assistant professor and researcher with a background in both linguistics and a PhD in medicine at Leiden University and at Mayo Clinic. So, sorry, what was that? You were cheering?
Yeah, linguistics. Yeah.
Oh, all right. Yes, and Marlene has a career that has started in shared decision making, has now with a Vinnie Award in the Netherlands gone into making care fit, and that continues to evolve. Not only is she a wonderful patient-centered researcher, but also brings two things that I value tremendously. One is an artistic eye and a sense of aesthetics of the work that we do. And as an editor of my own writing, Marlene has brought a level of kindness to the language that I use and to the work that we do that I think she exemplifies in the way she interacts with the world and the way she conducts her world work. And so it's a great pleasure for me to introduce Professor Marlene Kuhneman.
And just a quick check with those online. Are you seeing the presentation in its full form right now?
No, we're seeing the review.
We're seeing the preventer. Okay. No, that doesn't help us. Okay, hold on. Let me try again.
Yeah.
How about now? Mike, you're still seeing?
Now I'm seeing the kind of big view, but it's not, it's like frozen. It's not going up to the slide.
Okay. Oh, electronics, you guys.
Turn it up. Try turning on the slideshow
First.
Well, no,
Here we go. Let's see if I minimize this. Do you see anything now?
No.
Oh man. All right, I'm gonna stop sharing. Because I'm sharing. Should you share the screen? I did the screen. I tried to first okay, how about now, guys? Do you see?
It's the presenter view.
Still shows presenter view. I don't know why it's doing that.
I think you're sharing the window. If you share the screen picture.
That's what I just tried. Yeah, that's what I tried, right? Here we go. Oh, magic. Okay, I got it.
Yep.
Does it look good?
yes.
Yay! Okay, sorry guys about that. Marlene Kuhneman.
Thank you. Last speaker of the day. Bear with me for 45 more minutes as I go through a little bit more work on making care fit, both at the point of care and at the point of life. I'm very excited and happy to see all those familiar faces, friends and colleagues from years ago, and to also meet new people, and a big thanks to all the patient partners joining today. That's not working. Okay. Okay. I have no conflicts of interest to report. I don't receive any funding from for-profit organization. Yes, it is working. So still, for too many people, their care plans are designed without fully accounting for who they are, the lives they live, what matters to them, or what they aspire to achieve. So in other words, these care plans are designed for patients like this rather than for this particular patient sitting in front of them. And why is that problematic? Well, because these people may seem similar. They may have the same age, the same gender, the same condition. This person may be the primary caregiver for a family member. This person likes to go for daily 4-hour walks on the beach with a dog. This person likes to solve crossword puzzles on the couch. And then this person still works to complement their limited retirement pension. So there are differences in their situations and in their priorities, and we need to take these into account to determine what the best plan of care is for each of these patients. So I will be talking about care that fits. We need to make sure that whatever the problem is, whatever the situation is, our response to that problem, care, aligns with what is important to those patients and what their situation demands. And these efforts of making care fit usually start at the point of care. So during clinical encounters between patients and clinicians, as they try and design care plans. And this is sometimes called shared decision-making. And shared decision-making, there are many models out there, and most of these models distinguish a few elements. In most of these shared decision-making conversations, there is some form of fostering of choice awareness, so indicating that there is more than one option available and that whatever we do depends on what matters to patients. It includes discussing the different options, the pros and cons, and the probabilities of these pros and cons occurring. Discussing the patient preferences, and then making a decision about what to do next. But is this model of shared decision-making relevant for all the conversations that we have, for all the decisions that we make with patients? So let's dive into a patient case a little bit more. And this is from one of our studies. I'm going to look at the notes because I want to get the story right. So this patient, this person visited his diabetes doctor for an annual checkup. And the clinician told him that he had uncontrolled diabetes, that the current treatment was not working well enough, and that he needed to get the blood sugars down, either by strict diet and exercise, or the next logical step would be to start using insulin. And the clinician continued talking about the pros and cons of using insulin. And the importance of getting the blood sugars down. And the patient just sat there and didn't really say much. And after this lecture, the patient said, well, would I still be allowed to drive a bus if I take insulin? And the clinician said no. And he continued the lecture with more information for the patient. And after that lecture, the patient said, well, I'm a school bus driver. And if I start taking insulin, I would lose my job. I wouldn't be able to do my job anymore. I would lose my insurance, so I wouldn't be able to pay for the insulin. And then on top of that, he was also the primary caregiver for his mother with early stage dementia. And she depended on him and on his income. And this was actually also the reason I need to do all this. Yes, I was telling a story, but it has animation to it. The fact that he was primary caregiver to his mother was also the reason why he was spending almost half of the nights at her place, sleeping irregularly and forgetting to take his medication. So would the best response to this situation be to say, well, there's more than one option, and let's talk about the pros and cons, and let's talk about your preferences, and then make a decision? Or would the best response be to give this patient a decision aid to help him choose between the different options? I don't think so. This patient is in a problematic situation, a situation that is complex and undesirable. And he's not alone. We conducted 2 different studies in the Netherlands and in the US with patients with diabetes, and they indicated, about 1/3 of these patients indicated that their own situation was problematic. They used words that showed that they found their situation to be problematic. And these problematic situations then shaped the conversations. They formed the starting point of these conversations with their clinician. And in some cases, the patient's problematic situation justified the need to not make any changes to the care plan for the time being because other issues with higher importance need to be solved first. And then in other cases, the patient's problematic situation justified the need to make decisions to improve that situation. But often these cases didn't really fit well into the traditional shared decision-making model of taking those steps. It was really a trying on of options, of having a back and forth, a conversational dance between the clinician and the patient. And the starting point of these conversations usually was not, there is more than one option, or let's talk about these options. The starting point was the situation of that patient and how to improve that situation. So to me, shared decision-making is a core clinical activity, and it is a method, one of the methods that we have to reach our objective of making care fit. There's a little bit of a debate whether, there are different forms in which people can collaborate, and there's a little bit of debate whether we should all call that shared decision-making, or perhaps it's more patient-centered care or patient-clinician collaboration. I think that's a whole semantic discussion that we can have at a different moment. But there are different ways in which patients and clinicians collaborate in making decisions in real life. And I think that Dr. Ian Hargraves is also covering different ways of collaborating in his workshops tomorrow. And these efforts of making care fit are especially pertinent for complex situations. So what kind of complex situations? Well, these could be medical circumstances of patients. So for example, comorbidity. Too often comorbidity is not accounted for in either guidelines or in patient decision aids. They seem to be made for more clear-cut decisions and do not take into account the medical complexity. And considering multimorbidity is also hindered by fragmented care. It could also be complex life circumstances. And this could have to do with a certain stage in a person's life. So it could be about adolescents or young adults who are in the prime of their life, trying to enjoy life as they also are facing illness and treatment burden. Or elderly people who are increasingly dependent on other people. But it could also have to do with, for example, financial distress or people living in unsafe or abusive situations or environments. And then lastly, complex situations can also come from complex caregiving tasks that people may have. So they may be caring for their children, for their parents, for their partners, for family and friends, other people around them. And they're doing all these caregiving tasks, perhaps alongside of managing their own health and care. And that can be a full-time job. So we wanted to better understand what making care fit actually is. How do we conceptualize making care fit? And what do people do both at the point of care, so during clinical encounters, and at the point of life in patient's own personal environment to make care fit? So we wanted to look at both the conceptualization and the occurrence of efforts to make care fit. And for this, we did a few projects. We started with looking at expert opinions. We then looked at the literature and did a few studies at the point of care and at the point of life, which I will briefly present to you. So let's start with the expert opinions. So in 2021, I think, we organized a 2-day partnership meeting to reflect with people on what making care fit is and what the necessary conditions for making care fit are. So for this, we invited patients, their loved ones, clinicians, researchers, designers, and policymakers. And over the course of 2 days, we reflected on what making care fit is. This was an international group, as you can see here, and interdisciplinary, which means that each of these people had their own either personal or professional expertise. The outcome of this partnership meeting was published in BMJ EBM in a manifesto, and this QR code will take you straight to the open access publication. So in short, this group said that in making care fit, we need to make sure that we maximally respond to the patient's unique situation and priorities, while at the same time minimally disrupting their lives and their communities of care and their loved ones. This requires collaboration, both in the content and the manner in which people collaborate. And this is an ongoing and iterative process of constantly considering whether care still fits well or well enough, or whether we need to reconsider the plan. So with these dimensions in mind, we wanted to see what was already described in literature and about these relevant aspects of making care fit. And we call these aspects dimensions. And in particular, we wanted to see whether these dimensions are currently assessed in research projects. What we already knew from a previous review that we did is that humanism, respect, empathy, compassion is actually quite absent in shared decision-making research. So if we look at co-measurements or even mentions of aspects of humanism, we found that only 9% of SDM studies, original SDM studies, included at least one statement that had to do with humanism or respect or empathy. And that if we look at the SDM measures, that less than 4% of all the measurement items in all the tools include humanism or humanistic tone of items. So what if we not only look at the shared decision-making studies, but more broad studies looking at how patients and clinicians collaborate? We did a systematic review and screened over 13,000 papers, and we ended up including 142 instruments that had over 1,200 items that we could use to assess efforts of making care fit. And this was only at the point of care, so only efforts of making care fit during clinical encounters. The unit of our analysis were the items, so the 1,200 items, and each of these items was coded twice, first in one of the dimensions from the manifesto, and then second, we coded what kind of behavior this item was actually evaluating. What kind of main action is described in this item? So what we found first, looking at the dimensions, what we found was that actually 2/3 of all the items evaluated either the content or the manner of collaboration between the patient and the clinician. And just for the contrast, only 2% of all the items could be used to assess the conversations that patients and clinicians have on the impacts that care has on a patient's life. 2%, just emphasizing. In the second round of coding, we looked at the behaviors, and 30% of all the items assessed behaviors of informing. And again, for the contrast, need to look at the right numbers. Less than 5% of all the items could be used to assess behaviors of self-efficacy building or adjusting care to the individual patient. So basically, looking at this, the outcomes of the review, it seems like in studies, we are mostly focusing on evaluating, providing information, informing patients. We included this table in our paper. It has all the dimensions in the columns and all the behaviors in the rows. It is actually more lengthy, but kind of grouped it together here. And the paper also has an appendix that actually has all the 1,200 items divided into one of these cells. Our purpose was that researchers can use this table to decide whether to measure, for example, one particular dimension relevant to making care fit across all the behaviors, so focus on one of the columns. They can also focus on behaviors across all the dimensions, so focus on a row, or they can focus on a particular cell and look at the items that they can use to measure that unique combination of a dimension and a behavior. Okay, so we had the expert opinions and the literature review, and then we wanted to see what happens in clinical practice, so at the point of care. In this study, with the purpose of confirming the dimensions that we previously had, and I forgot to say that in the review, we actually also identified a new dimension of unhurriedness, so the relevance of having unhurried conversations at the point of care, but also having feeling unhurried as you try to make care fit in your own personal environment. So with the purpose of confirming the dimensions, we did a qualitative study looking at conversations between patients with diabetes and their clinicians. And we purposefully sampled the patients based on their biology, so their disease and care characteristics and their socio-demographics, but also based on their biography, based on the stories that they shared during their encounters. So, for example, we included 2 patients. They had the same age and kind of a similar treatment, but one was a full-time caregiver to his wife, and the other one spent quite some time abroad on active group holidays. And we wanted to make sure that we had a very heterogeneous sample, both in terms of biology and biography. So we were indeed able to confirm all the dimensions, and we saw examples of how people are making care fit, are trying to make care fit during these encounters, except for the dimension of unhurriedness, which we didn't see, I guess, because it is not often an explicit topic during these conversations. And we were also able to enrich our concepts with practice examples. So, for example, this one is about the patient's situation, and more specifically, the patient's problematic situation, where the patient says, well, work is actually the biggest negative factor. It makes me do all the other negative things too. If that becomes too much, I will sleep less. That will make me hungry, make me eat wrong. I feel less like moving, and then it all spirals down and the sugars go up. This one is about the impact of care on patients' lives, where the patient said, well, by the way, I stopped using the pump because it drove me crazy. It leaked so often, so I stopped during my pregnancy. I talked to the nurse and I said, I'm going back to the pen because I just need to know what goes in. And this one is about the impact of care on patients' communities of care and their loved ones, where the clinician asks, you're not alone, are you? And the patient says, no, I'm with my daughter and I always have her around. I recently went over how she should inject, which one for the day and which one for the night. She's 14. She doesn't like it, but if she has to, I think she will do it. Then in the same study that I mentioned before, about 1/3 of the patients indicating that they were in a problematic situation, we actually found evidence in 86% of the encounters that patients and clinicians were actually collaborating. We also used a common shared decision-making measures, and that was only correlated with one of the approaches of collaborating. So with the current shared decision-making measures that we have, we are actually not picking up all the efforts of patients and clinicians in trying to make care fit. So when clinicians say, well, we're already doing it, perhaps they are, but they're not doing it according to a theoretical shared decision-making model with the measures that are designed to assess that particular model. So, point of life. We have talked about the point of care, and you design care plans, but then patients go home and they have to actually implement it. We have to make sure that it makes intellectual, rational, emotional, and practical sense. And we wanted to see what patients do in their own personal environment to make care fit. Because in this environment, this is where patients work to modify the care plans and to adjust either the care plan or their lives to make it fit in real life. And for this work, we focused specifically on young adults with type 1 diabetes. We were particularly interested in this age group because research has shown that these young adults have higher glucose levels compared to other age groups. And they're also higher now than they were a decade ago. In general, we can see that young adults with type 1 diabetes have worse medical and psychosocial outcomes compared to other age groups. And they are in the prime of their lives. So every time their situation changes, they move out, they start a new education, they start their career, have a new job, get engaged in romantic relationships, start a family. Every time that situation changes, you need to reconsider, does my care plan still fit well in the life that I want to live? So we asked young adults about their investments in care, in time, energy, and efforts, and half of the young adults indicated that their investments are unsustainable over time. So this means that they are at risk, that they are overwhelmed by their care. It also means, well, and this is, by the way, twice as high as for other people living with diabetes. So it's much higher. And this means that at some point, aspects of care will not be implemented by these young adults. And then we will label those as being non-compliant and non-adherent young people. Well, in fact, the care plan just didn't fit well. So we need to reconsider. Or even though it is unsustainable, they are trying to stick to the treatment regimen and implementing the treatment, but only at the cost of those things that make life worth living in the first place. So that is wasteful and it's harmful. And this is what they said. You want to live a fun and spontaneous life, but you also have to nonstop keep an eye on your sugars. Food, everything you have to do then. That's why I sometimes just skip my meals. I use a do-it-yourself looping system. I did tell my clinician, but he wasn't interested. Or I bolus less insulin to prevent hypos. Tomorrow there's a session with oral presentations, and my colleague Anka van Gastel, who's in the back, will present this research in more detail. After the survey, we conducted a photo voice study. This means that we asked young adults to show us what it's like to live with diabetes and to show us all the efforts to make care fit in their personal environment. So what is the impact and what do you have to do? And here you can see some of the examples of the young adults' pictures. So in the first one, someone is traveling, am I immigrating? Well, no, it's just a weekend trip, but it's a bag filled with diabetes medication. The second one was a social event where someone already had high blood sugar, so she couldn't really fully enjoy that event and not take any snacks. And the last one is about studying, sitting down all day, making sure that you increase the target value to make sure that you don't get in trouble. Here, the first photo is from someone who was late for an appointment, had to run, and then got into a hypo. So she needed to sit down and rest and recover, and obviously was late for her appointment. I felt sad about that. The same for sports, where you sometimes just have to have the energy drinks. And the last one, the example was of someone who had a clogged infusion set and needed to replace that in the train, in a busy train, with people watching her doing it, and she felt really embarrassed about that. Again, my colleague Anka van Gastel will present this work in more detail. We received over 240 photos from young adults, and she has a really great overview in one of the poster sessions on Thursday, I would say. It's Thursday? Yeah, okay. Good. Okay, so what does all this research mean for making care fit? We use the expert opinions, the literature review, the observations in clinical practice, and at the point of life for our conceptualization, which now includes 9 dimensions of making care fit, each with their subdimensions. So first, that should have been a nice animation. So okay. First of all, in Making Care Fit, we need to maximally respond to each patient's unique situation. This means medical situation, but also personal situation, and it can be a problematic situation, as we saw in our research. Oh, seriously? We also need to make sure that we maximally respond to patients' priorities, their wishes, their needs, their goals, and their worries. At the same time, we need to minimally disrupt patients' lives and those things that make life worth living. This means that we need to take into account the work of being a patient, which is oftentimes a part-time job, and the impact of care on life, but also the impact of life on care. We also need to take into account the capacity that a patient has to deal with all this. And for example, devices can be of influence to decrease or increase the impact of care. We also need to make sure that we minimally disrupt patients' communities of care and their loved ones. We need to consider the experiences and the work of the communities of care, but also the impact on relations that patients have with their communities, and need to find ways to support the communities of care as they are helping their loved ones. Okay, this requires, and it usually starts with collaboration between a patient and a clinician. This is collaboration, as I said, both in the content of the conversation. So here we are talking more about classical shared decision-making, making patients aware of the options, discussing the pros and cons, the values and preferences, but also discuss the sensibility of the care plans. So the how sensible, rationally, emotionally, and practically is that care plan. But also collaboration in terms of their manner. So tailoring the conversation, building and maintaining a relationship that is based on mutual respect, on willingness to accept each other's contributions in that conversation, on humanity, on empathy, on dignity. It also involves agenda setting of the collaboration. This process can be supported by, for example, decision aids or conversation tools, but doesn't have to be. And we also saw some examples where a clinician provides a little bit of context about their own situation to help build and maintain that relationship. As I said, this is an ongoing and iterative process where you look at future care planning, where the continuity of care and continuity of life can be an important factor. And every time the situation changes, you need to reconsider and possibly adapt either the care plan or life. Adapting can be medical, it can be personal, and so in some cases we also saw examples of organizations changing and needing to reconsider the sensibility of the care plan because now care is organized in a different way. And lastly, this is all a process of unhurriedness, both in the conversation and as patients go home and try to make sense of their care plans and implement their care plans in their daily lives. So many of the participants in our studies have their own complexities, and some of these complexities we've seen in the examples in the qualitative studies and in the stories that they shared. But importantly, patients also have increasingly have heavy caregiving burdens, trying to take care of what I said, children, parents, loved ones, and all of this in, well, a demanding environment that basically never rests. I want to take on this challenge of looking into the effects of caregiving in making decisions and designing your own care plans. And I very welcome everybody who's enthusiastic to join me on that quest. and to start thinking about how to do that. Okay, so to conclude, I've presented some research and views on making care fit, both at the point of care and at the point of life. I've talked about how shared decision making is one of the methods that we have available to reach our objective of making care fit. These efforts to make care fit start at the point of care, usually, and continue at the point of life in people's own personal environments. And we need to make sure that we maximally respond to patients' unique situation, their problematic situation, and to their priorities while minimally disrupting their lives and those things that make life worth living. Thank you.
We have a few minutes for questions.
Yeah.
And I'll check online, see if we have any voices. Nothing online so far. Okay.
There you go.
Yes.
Thank you so much for the presentation. My name is Felipe. I'm a physician from Peru. I'm a researcher at the Care Union. And this is very interesting to me, especially besides the 2%, but also the impact that we lost, 9% and 4%, where you were referring to humanism and shared decision. It's very interesting to see because maybe my perspective of it is different to what has been done, in that shared decision making is a deeply human activity, and it involves like caring and making the patient's life important to your practice too. So it's very interesting to see, but I guess I have to ask, why do you think that it's not as touched in these tools or in this research?
Repeat the question.
Yes, so the question is why humanism is basically why shared decision-making studies and shared decision-making measures are not paying enough attention to humanistic factors of communication. Yes. So I think that has to do with that. So most of the studies use some kind of shared decision-making model as they move forward and determine what they are going to evaluate in their studies. And as long as these models are very exclusive of all these humanistic aspects, probably those studies won't be focusing on those aspects either. And I think we are at risk that if we look at shared decision making as creating choice awareness, discussing the options, discussing the preferences, making a decision, that you can kind of check all the boxes, but you see a conversation and you know that it's just not there. And you have to give very high scores to conversation that you really don't want to reward with higher scores, because you could see that care was not part of that shared decision-making process. So Victor and I and Nilesh Shah wrote a paper on this called Measurement with a Wink, where you can say, well, we kind of evaluated it, and now we have a number, but what do we really know about what it says if we know that it wasn't shared decision-making as a core aspect of care, but it was taking the right steps in the right sequence at the right time. And I don't think that that's enough.